We are live.
So good evening, friends, and welcome to this monthly webinar of ARC IOS. Because there is a lot of commotion and noise around me, I will request Anaga, our member ARC West, to continue the proceedings.
Thank you, Dr. Prashant. A very warm welcome to everyone here. We from the AIOS ARC are today starting this webinar. It's a webinar on complex cataract surgery. So cataract surgery is our bread and butter. We are doing it day in and day out. However, there are many situations which are very complex and they require bold decisions to be made. So we have put together few talks and few videos. The talks would be basically on special situations in cataract surgery and how we are going to decide what is best for our patients. So it will be 5-minute talk with 3-minute discussion. Then we have a very interesting session called as Oops Surgical Disasters and Comebacks on very complicated surgeries and how decision making in those situations helped us bail out and give us the best visual outcomes. We have another session called as the Showdown, my most challenging case, where challenging cataract surgeries would be presented and we will have a discussion by our expert panelists. And we would be ending with a grand round session called as What Will You Do? A few situations would be presented and our expert panelists will debate as to what would be the most optimal decision in that situation. So I would like to welcome our expert panel. Dr. T.P. Lane sir, Dr. Jivin Titial sir, Dr. Praveen Krishna sir, Dr. Suhas Haldipurkar sir, Dr. Namrata Sharma ma'am, Dr. C.V. Gopal Raju sir, and Dr. S.J. Sai Kumar sir. So we have a galaxy of experienced and brilliant surgeons today here with us. We are very fortunate to have our webinar studied with such great gems, and we are sure that all our delegates and the viewers are going to get the best out of the discussions today. So we would be starting with the first talk. Dr. Cyrus has requested for an early talk. So Dr. Cyrus, he would be speaking to us on a complicated, challenging case that he would be performing, and we would have a discussion on it. So over to you, Dr. Cyrus. Yeah, please share your screen.
Can you see my screen?
Dr. Cyrus, can you just stop share and then reshare?
Okay.
I'm stopping it. Now you can reshare once the PPT is open.
No, it's a video.
Yes,
Can you see it?
No.
sir, you need to reshare, please. Same steps, share button. Yes.
Yeah.
Uh,
Can you see the video?
Perfect, sir.
Yes.
Videos come?
Yes. You
Yeah.
can play it now.
You
Yeah.
can see that blue
Yes, please play
intro.
it. Yes.
Okay. So this is a very interesting case, and thanks so much, Anaga, for having me. And she's told me to speak about subluxated lens. So instead of speaking about subluxated human lens, I wanted to speak about subluxated IOL, or more appropriately, dislocated IOL. So this is a very interesting case. This patient came to see me when he was faking. And when he was faking, he had multiple episodes of uveitis, and I'd done a regular cataract surgery for him. And after that, every 6 months, 1 year, uveitis would recur. And over time, the zonules gave way and the capsular bag started to subluxate. At that point of time, we just waited and watched. One day he comes with the lens and the capsule and everything lying on the macula. So at this point of time, what do we do? Normally, I would have simply done a reverse iris claw fixation, which is less traumatic for the surgeon and the patient. But in view of recurrent uveitis, I decided to do something different. So I'll mark the eye 2 millimeters on either side of the midline. And go in with a 25 gauge trocar. Now we do a scleral tunnel. And the tunnel is about 5 mm. Now where the marks are, 4 25 gauge trocars. So there's now 5 trocars in the eye and 1 scleral tunnel. If you look inside, you'll see the bag and IOL and everything lying right there on the disc and macula. So we put in PFCL and then levitate the whole thing into the anterior chamber. Move the biome out of the way and get it up into the anterior chamber. Make sure it doesn't fall back in. Then just reach in with the McPherson's and pull it out. This is basically a Rayner, which I'd implanted about 5 or 6 years ago. So you can see because of multiple episodes of uveitis, whole bag and IOL complex, everything had dislocated. There was one suspicious looking area which I lasered in the paramacular region. And then remove that bubble of PFCL. Now we take a Gore-Tex suture. So this comes in a pack of 12 sutures. It's basically like 7-0. And the Acryos lens. This is a 4-loop IOL, but you can use any IOL with 4 loops. So now what you have to do is thread it. Cut the suture into 2 basic pieces of about 4 inches each. Now you can see the 25 gauge forceps going through the 25 gauge trocar. Pull it out of the eye. So now you have the lens, the leading part of the lens fastened with the 2 Gore-Tex sutures. And exactly the same thing on the other side. So this is really simple. You just pass the suture through. And the advantage of Gore-Tex, it will never degrade. And especially in an inflamed eye like this, I thought this was the best choice. And the 4th one. So this slightly large lens, which is what I wanted. So we fold it and insert it. Like the olden days that you had a holder folder. Nowadays, I think most people have never seen a holder folder, the new generation of ophthalmologists. Everyone's used to an injector. Make sure you don't cross the sutures over. That's the only thing to take care of. Then you pull on the 4. And now remove the cannulas and do 3 throws. Now you can still adjust the suture at this stage. So you tighten it on each side. See that the lens is sitting nicely in the center because it's quite a large lens. So you have a large optic. And then you lock it by doing 2 throws more. And the advantage is you can just push the knot into the opening. So this knot will never come out to irritate the conjunctiva or to irritate you in future. Close the conch. And this should be the end of it. So this is a nice, simple and easy way when you don't want to tamper with the iris. Otherwise, I would just have done a reverse iris claw fixation.
Great. Cyrus, can you please unshare?
Yeah.
Yeah, so this was a very interesting case because this was a case of recurrent uveitis. Dr. Namrata Sharma, ma'am, is there? Huh, ma'am. Yes.
Yes,
So this
Anaga.
is a yes, ma'am. So this was a very interesting case which Dr. Cyrus has just presented. So how often have we seen recurrent chronic uveitis causing zonular dialysis like this and entire back complex dislocation? And we today have so many options like CMT flex or Yamani technique and glued IOL. Which one do you think in this situation would have been the most appropriate? And what do you have to say about his technique?
So I think that was a very well managed case, and Cyrus could probably do it because he can tackle both retina and cataract. But in this case, glue dial could have also been done. CMT flex, of course, I think it's a hydrophilic lens. It's a hydrophilic material. And whether recurrent attacks of uveitis can cause dialysis or not, I think it can cause, because of inflammation, it can cause some amount of zonular weakness. But of course, he used Gore-Tex, and I really don't know how Gore-Tex behaves in cases of uveitis. But because of the fact, the way you are, you know the technique. For instance, I would rather do a glue dial because I know that technique better than I would know Gore-Tex fixation. But I think this is also a good way of doing it. And if you are well versed with fixation with the Gore-Tex suture, then I think the results are quite okay.
Dr. Titial, sir, your inputs?
Yeah, as Namrata rightly spoke on, the techniques. Any techniques, which safeguards the uveal tissue would be better because this patient would have a recurrent uveitis even after this fixation also. I think one of the important thing here is to, for people who are seeing this video, is surgical technique is, whichever surgical technique they are expert should be done without the least damage to the, structures. Assessment of patient is very important because we are not going to prevent uveitis in this patient. The posterior segment assessment, he had to do a laser in one area. And why this patient has a uveitis, recurrent uveitis, that too in this eye, has to be, should have been investigated or would have been done by Cyrus. And that is another important point. And CME development is a very serious concern in this patient. That part we have to check. And pre-op examination and proper counseling would have been a very effective way for a decreasing post-op chair time with this patient. As far as technique is concerned, a technique which requires at least opening in the scleral tissue in a long-term wise may be better because I'm not sure whatever uveitis patient has, you can have a scleral thinning happening in the long run. So maybe two opening would be sufficient, but this will be a very small incision opening. And Gore-Tex we know is a very safe suture for a long-term wise. Only concern here would have been, the associated uveitis and glaucoma, which may be another important factor here. But Cyrus tackled this patient. It looks so simple, but I'm pretty sure it's one of a difficult procedure to be done in such a easy way. And I think expertise should be there. I would rather refer this patient to people like Cyrus only, who can tackle both anterior, posterior, intermediate area also, because this patient may have been having an intermediate uveitis, which is major concern in these patients. But well done. I think people seeing this, you should investigate your patient appropriately, counsel them, and have a long-term follow-up, which Cyrus did in this patient. In fact, he should have tackled this patient, 1 or 2 years before when journals were started, getting loose. so that the lens will not have dropped in the vitreous cavity. And that I think we have to make sure, like we tackle the patient before it goes to that stage. That is also learning for us to know all patient where you can think the zonular support will go down, like a chronic uveitis, pseudo exfoliation with the degenerative changes. We should see them regularly and make sure we intervene before this type of thing happens. But nicely managed.
Yes, yes, very nicely managed. Only one question was, this was a hydrophobic acrylic lens, right?
Hydrophilic.
Hydrophilic acrylic, right? So what about the irritation near the ciliary body where you're going to pull it? Or maybe like Dr. Namrata Sharma madam said, if we use glued IOL, then will the change in the material, especially in this case, matter?
I think, bulk may be the concern because these hydrophilic lenses are little thicker and can have a, irritation to uveal tissue. But proper centration fixation may be all right. But if you do a scleral fixation, those lenses are little far behind than the actual, uveal areas. So maybe safer. But ultimately, if you look at it material-wise, I don't mind putting hydrophilic in these cases because they are more uveal friendly. So you will not have a deposition happening, a uveal deposition pigments on the lens surface. But they might get opaque in a long run with a lot of inflammation. That's the only concern. Otherwise, these lenses are very uveal friendly lenses.
Thank
As
you so much.
Vortex is also concerned, it is supposed to have less amount of reaction.
Yes.
So that way also it is a UVA friendly suture.
Yes, thank you so much. And thank you, Dr. Cyrus, for that nice presentation.
Thank you all.
Yeah. So we now move on to the first session talks is about an unusual cataract situation. What's going on in these cases? And we would be presenting Dr. Vikas Mittal's talk on managing cataract in keratoconus. Unfortunately, he's traveling. So he has recorded this video and we'll be playing it. Yeah, Mr. Sunil, you can just play
At the outset, I would like to thank All India Ophthalmological Society for this opportunity. I'm going to talk on how do you manage cataract in a patient of keratoconus. Let's see a few scenarios. 50-year-old male came for cataract surgery and diagnosed keratoconus while doing a workup. He had never heard of keratoconus. Second, 48-year-old female keratoconus diagnosed using RGPs and now has developed nuclear sclerosis. Last scenario, young boy, known keratoconus, known allergic conjunctivitis and now has developed PSC or posterior subcapsular cataract. How do we approach these patients? Is it the same way that we do our routine cataract surgery or there'll be some tweak here? That is what we are going to do, and I have divided it into how do you deal with these kind of patients pre-op, intra and post-op. Let's see what do you do before the patient is taken into OR. Counseling is very important. We have to set the expectations correct. These patients are not the ones who will not need any glasses or contact lenses after the surgery. So those expectations has to be very clear and the need of glasses and contact lenses has to be stressed upon. When do you do surgery? This is a very good algorithm published in Indian Journal of Ophthalmology. When do you do the surgery? When the patient cannot do his activity with his glasses or contact lenses. And there is no specific treatment of keratoconus is pending. IOL power calculation is the main challenge that we have to face when we are planning a cataract surgery in keratoconus. And why? Because these have a irregular corneas and then axial length also because the cone is slightly eccentric and the IOL formula becomes challenging. So let's take them one by one. Before that, before you take the patient for biometry, ensure that the patient is off contact lenses. In case of hard contact lenses, at least 2 weeks, soft contact lenses 1 week, so that corneal warpage does not interfere in it. Scleral contact lenses are generally, they don't cause much of corneal warpage. Ultrasonic biometry to calculate axial length may not be a great idea. So optical biometry is what is preferred because that way visual determination is more accurate. For keratometry, these as I said, these are the corneal curvature is really altered. So standard K index when we take that becomes slightly problematic, and How do you calculate the k? With the k that you have to take, where do you get it from? It's better to take it from optical biometry and other machines like tomographer, topographer, and manual keratometry and ARK should be avoided. What we do is we take the k values from all the different machines that we have, and see which is the least k that is there, and that is what we feed in the formula, because this way you will actually get a myopic refraction which will be better tolerated with the patient. And which IOL formula, if you use, there are many articles on different kind of formula for keratoconus, but what we standardly use these days is a cane formula. This is available online also, and it doesn't require any additional variables. So same variables, same A constant is used, and as I just now said, that we need to target a myopic refraction. IOL choice, monofocal as ideals. Can we use toric? Only in case of mild keratoconus where astigmatism is slightly irregular, but as these are not those common. Most of the patient, they have irregular astigmatism, so better to use only monofocals. Of course, the advanced premium lenses like advanced monofocal EDOF is better not to induce any other aberrations, because there are already a lot of aberrations due to cornea. Intraoperatively, these corneas are thin, but periphery is thick enough. All you have to do is ensure that you have a good 3-step incision so that you don't land up with leaky wounds. Sometimes intraoperative visibility can be challenging because of irregularity. So in those cases, you can use a viscoelastic over the cornea, or even sterile rigid gas permeable lens also that is placed over the OVDs. Postoperatively, patient have to use glasses or contact lenses, depends on how irregular the astigmatism is. You may need to do IOL exchange or piggyback IOLs, but only when the vision is actually improving with glasses, not with the contact lenses. And because irregularity can be taken care of by contact lenses only, that will not be taken care of by the IOL exchange. So overall, we need to set the expectation realistic. Optical biometry is better. Use the lower cane formula for IOL power calculation. Smooth astigmatism is rare, so as a thumb rule, spherical monofocal only, and incision should be good 3-step incision, and patient will need glasses or contact lenses after the surgery. Thank you so much for your patient listening.
Yes. That was a really excellent presentation by Dr. Vikas Mittal. Dr. Praveen sir, are you there? So wanted to ask you, in your experience in all the types of keratoconus patients, what would be your experience in how, when you're dealing with them, to take the keratometric values, which would be the most accurate and which would we avoid?
Interesting question, but I think I would divide keratoconus patients with cataract into 3 potential categories. Vikas gave a very nice overview of what to do in a patient with keratoconus and cataract, but I think for the more practically oriented, I typically try to understand if the patient is comfortable wearing contact lenses or not. If a patient is comfortable wearing contact lenses and he has been wearing contact lenses for several years, uh, I would not use a toric lens. I would use generally either, now people have been suggesting the cane formula, or in general, the SRK2 formula also is relatively accurate in patients who have keratoconus, and use the keratometry from the topography and put in a spherical IOL and get them to continue wearing their contact lenses after surgery. The second scenario is patients who have mild keratoconus, and you can use a toric IOL. These are typically younger patients who have a PSC or a cataract because of steroid use. These patients do really well with a cataract surgery and a toric IOL. And these are typically patients whom you don't expect to use a contact lens post-op, because then you will negate the toricity of the lens inside the eye. The third category are patients with relatively severe keratoconus whose vision is compromised even with a contact lens. These patients, I would do a transplant first. I would not do the cataract surgery. And after either a DALC or a PK, and after all sutures are out, if the cataract is not very dense, that's when I would do a toric IOL. And if they have a cataract that is relatively advanced, I'll wait for between 3 and 6 months, and then I'll do a spherical IOL and then give them as good uncorrected visual acuity as possible. So three scenarios I can think of with keratoconus and cataracts.
Right. Great, sir. So,
But,
yeah,
uh,
yes.
Parveen, just for a clarity, let's cases with irregular cornea. The keratometry readings are very tough to obtain, which will be useful for a calculation. Suppose we do, as he said, now we can do a topography or tomography. So what will be your call on that? What reading we should take from there? Like it should be a 3 millimeter, 5 millimeter, or you go for EKR value, which will be the apt for people to understand.
Generally, EKR value is useful when the relationship between the anterior and the posterior surface of cornea is sort of disturbed. When it is not, the EKR generally is not as valuable. So I think, sir, either the EKR value or the average 3 millimeters topography K from the whichever topography machine that you're using should be good enough to calculate the lens. And if a cornea is very irregular, most of these people will only have good vision with a contact lens. So even if you go wrong a little bit with the IOL power, you're all right because you can dial that into the contact lens power is my guess.
I think that's a very good point.
Can I can I
Praveen.
just add a couple of points
Yes,
to
yes,
what
yes,
was
Dr. Anand.
discussed?
Yeah.
So I think from my experience of working with keratoconus patients, I think the younger patients tend to do better with any intervention. The older patient, anything beyond 50 is definitely a challenge. But topography sometimes helps in quantifying the type of astigmatism. What I've realized in keratoconus is all astigmatism are not irregular. There may be a asymmetric bow tie, but the bow tie amount in terms of skewing may not be significant. So my call is that anything with skewing more less than 15 degrees, you can still go ahead with trying a toric lens. So skewing is an important part, especially on tomography and topographies. The second part is in terms of the imaging, I find the central 4 millimeter or 3 millimeter, depending on the type of topographer you have. If you take the average corneal power, you're not aiming for a 6.6 most times, sir. So I think what Praveen and Dr. Dityal are probably alluding to is that you choose your cases. So anything beyond, I think 55K is where you were probably looking at a contact lens, definitely post surgery, or maybe a transplant followed by a intervention for the contact lens. So, but I found that anything, if we have done surgeries even post intacts, the challenge is always going to be getting them off the contact lenses. But if you have regularized with intacts or a keratoplasty, any corneal intervention with a toric lens actually may be significantly giving them better uncorrected and best corrected vision.
In fact, a lot of
question,
our
one question to Praveen. Suppose you do a keratoplasty in these patients, as you talked about, and then you put a toric lens. Suppose you have a residual astigmatism, then you put a toric lens. Unfortunately, suppose you have to redo the keratoplasty subsequently, then how does this toric are going to work? It's a challenge I have faced in many patients, and I realized I should have put the spherical lens in those patients, because I had a few patients who had to redo my DALK and they had a different toricity subsequently.
So there are a few, I mean, very good questions and very pertinent. I think one of the lessons that I've learned is now if you have a keratoplasty and then you do a toric IOL, since now luckily we can do DSEC in a lot of these patients, it won't alter things too much. But the problem with that is if the toric lens that you've used is a hydrophilic toric lens, then the air bubble that is used in DSEC can cause opacification, which again complicates the whole issue. So I think I'd use a toric lens if I'm expecting that I'm going to be doing a DSEC later on. There is a technique that I've learned from Nicholas Pereira right now. He uses a blob of viscoelastic on top of the lens and then puts air so that the air is not directly in contact with the IOL. So that sort of, he's reported that he's not had opacification. I've started doing that now if there is a toric lens in the eye. But you're right, I've had scenarios where there's a toric lens which I couldn't take out of the bag. And then we had to remove sutures so that the astigmatism in the graft aligns with the astigmatism in the toric IOL. So it's sort of reverse.
Yeah, I
Yes.
had, but two cases of granular dystrophy
Yeah.
where I had done a DALK in these patients, and I subsequently did a,
His frame is frozen, I think, some net issue. And one more thing is where all
Hello?
our, sorry, sir, I think the last few words were not.
Doesn't matter. Carry on, carry on.
So another thing is for our routine cataract patients today with multifocals and EDOFs coming in, people are rushing into toric multifocals or toric EDOFs. But if they are not doing topographies for these patients, many times we may miss out on keratoconus patient, and many times these patients post-operatively are ending up with either a residual refractive error and not a good quality of vision, especially premium patients with trifocals with irregular corneas can become a difficult situation. So one more take home message is for all astigmatism patients where we are contemplating a toric IOL, we should always screen them with a topography and ensure that it is a regular astigmatism. And one more question before we move on. If it's a very severely aberrated eye where the probably even K-metry readings are not possible or they are very high, would you advise taking a general average figure of 44 or 43.8, like it's mentioned in literature? In which cases would we do that? Dr. Praveen, sir?
I think the keratometry, the actual quantum of the keratometry is more a function of whether the astigmatism is regular or not. Because once the keratometry starts to become a lot steeper, then the astigmatism also, you have a more irregular component. And those are the cases that you are more likely to do an intervention like a keratoplasty or a regularization procedure before you do an IOL. And generally, when the keratometry, like Anand was saying, is not as steep, the likelihood that the astigmatism is regular is higher, which is when a toric IOL will benefit patients such as this. So I think there is no cutoff number for keratometry that says that you should do one or the other interventions. But I think the likelihood of the regular astigmatism, and I think the history is very important as well. If somebody who has keratoconus has been comfortable with spectacles before they develop their cataract for a long time, by all means go ahead and put a toric IOL. If they have been dependent on contact lenses, then don't put a toric IOL, but put a spherical lens and then give them to continue their contact lenses after surgery.
Yes. Great, sir. Thank you so much, everyone, for the great inputs. We'll move on to the second talk. Dr. Tushar Agarwal, can you please share, sir? He would be speaking to us on hitting emetropia in post-RKIs.
Hello everyone. Am I visible and audible to everyone?
Yes, yes.
Okay, so I'll be talking about a case of operated RK underwent cataract surgery. This was a 58-year-old male with an immature cataract. He had undergone RK elsewhere 32 years back. In Switzerland, there were 8 RK incisions in each eye, and there was a grade 2 to 3 nucleus sclerosis. This is the summary of his ocular findings. The UCVA was 624 in the right eye, 660 in the left eye. I'll focus on the left eye, which we tackled. And he had a refraction of plus 4.5 diopters with 2 diopters of cylinder. And the video keratography showed a keratometry of around 33.5 degrees average. When we did the IOL master in him, the keratometry actually showed less than 30 diopters, and the IOL master doesn't calculate below 30 diopters. We also did some other, repeated the video keratography with other modalities and found that the pentacam and at about 3 millimeters of optic zone showed a keratometry of 29.03 and 30.61 with an astigmatism of around 1.5 degrees. So we calculated the IOL power using various methods. The IOL master, of course, didn't give us a default reading because the keratometry fell below 30 diopters in each meridian. Then we fed the VKG values in this, and then we also used the Asker's online calculator, which itself uses multiple formulas. So we ended up with the whole range of powers. Of course, SRK2 is just given as a reference that these formulas, the older formulas, tend to severely underestimate the IOL power. The Barrett's 2K gave a power of 22 diopters. The Asker's calculator gave us a range of IOL powers ranging from 23 to 28.85 with an average of around 26.8. And the consensus statement of the Askers itself says that in these scenarios, use the average formula, average power given by the calculator. So we went with the Technis enhanced monofocal lens with the power of 26.5 diopters. In the video, I'll highlight some of the standard variations which I do in such cases. The first is the incision site. In this case, fortunately, the layout of the incision was such that I could make a 2.2 clear corneal incisions right between the two old RK scars. The positioning of the side port, either you can choose this area or this area. So I chose the left one, which gave me almost a 90-degree away side port access. Again, taking care that my side port is between the two RK scars. And this is the second side port, again, staying away from the RK scar. Visilon on the cornea helps in such cases as it sort of increases the visualization in the eye. My standard technique is to create the flap with a capsulotomy needle and then complete the rexes with the help of a forceps. Remember, these are highly myopic eyes. When you're doing rexes, if you just keep following your old intuition of following the iris, you may end up with a very large rexes. So I always try to ensure that I keep a very big margin around my rexes. The rexes actually should visually look smaller. Only then you have actually achieved a good rexes size. Of course, hydrodissection and delineation. This part of the surgery is, as in any other case, followed by phacoemulsification of the nucleus. And I'll come to the more pertinent parts specific to this case. Before IA, I don't like to hydrate the main incision in these cases, so I always pass a suture. So before that, so I'm sorry, for the IOL, the incision has to be enlarged slightly. One has to ensure that the cartridge goes right into the incision so that no part of the IOL actually comes into the contact with the cornea, as that pressure itself can lead to the opening of the RK incision. So you're trying to avoid the pressure so that the cartridge is taking all the pressure of the folded lens. If required, you can even enlarge it further if the cornea allows, so that the cartridge actually goes inside the chamber. So as I said before, I like to pass a suture in these cases because I will not be hydrating the main ports in this case, because that also can lead to opening up of the incisions, or in some cases can lead to leaky post-op incisions. So with this pre-placed suture in place, the IA is done, the viscoelastic is removed thoroughly from front and from the back of the lens. And once the suture is tied, I just hydrate the left and the right side ports, taking care that the flow of the BSS is away from the superior RK incisions. And this is my standard go-to technique for handling such cases. So this patient was operated on last Thursday, and he came for follow-up today. The UCVA is 612, but he is still accepting plus 2.5 diopters fair and -1 cylinder. I do expect the sphere to go down a little bit in the post-operative period, probably to around 1.5 diopters fair. So the learning in this case is that rather than going with the average, a better choice probably would have been to go with the higher end of the range given by the ASCAS formula. Of course, the Barrett's, Pruke, and the other formulas were not of any use in this case. Thank you.
Great presentation, Dr. Tushar. One thing is, in these patients, we usually aim. Can you please stop sharing, sir? Yeah. We usually aim for a little myopia, right? So even though your average was 26.5, we usually aim for 1 or 1.5 diopters
Yeah, see,
myopia, so that we don't end up having hypermetropic.
yeah, so see, thing is that we use our other go-to formulas. We follow a system at RPC since long that if there is any trouble with the usual formulas, we calculate using SRK2 and add 30% to it. That's around multiply the power which you're getting into 1.3. That's our baseline sort of from where we start looking for other options. And all of those formulas were giving us a power which was close to 23, 24. So as such, when we saw that we are getting a range of range of powers from the ASCRS calculator ranging from 23, 24 to 28, and they themselves say that go for the average power. So that's why we chose the middle power.
And when these patients usually, it is known to have variable K readings during the day because of diurnal variation. So did you repeat these readings and did you get any consistent readings which you took, or did you take an average, or what?
So this patient, he underwent biometry actually 2-3 times and at different times of the day. But there were some variations, but they did not make any material difference as to the calculation of the IOL power. So the net K readings remained more or less similar. So there was no significant jump in the K readings.
Yeah. Dr. Namrata ma'am, in patients who have very higher number of cuts, say 20 or 30. So in these patients, obviously to get a place with 2.2 millimeters become very difficult. So would you suggest using a scleral incision in these
I
patients?
think it is better to go a little bit more scleral in these cases than you would do normally, because otherwise you will be cutting the incisions themselves. So as far as this case is concerned, I think this case was dealt very well, and this is a norm. I mean, whatever you do, post-RK patients, they tend to be hyperopic only, so you should try to go as much myopic as possible. And all the features of myopia did feature in this case, like a breathing pupil, like the cataract, which is, harder than the red glow, suggests hydromaneuvers, which have to be done very copiously. I think Tushar beautifully explained the sizing of the rexes. And these cataracts, they tend to occur in younger age group because of myopes. So vacuuming and polishing is also important so that you don't have PCO in these cases. But regarding the power, there may be a little variation. Of course, you need to get more than on multiple instruments, you need to get keratometric values. And we have that facility here. And
Like a query for
the
Dr.
keratometric
Namrata,
values,
Tushar,
the
and
keratometric
Dr.
values,
Vidyal.
sorry.
Yeah, no, just because I think you probably have the largest number of series on RK, considering your experience of three of you put together. I was just curious if you've actually seen any variation in the recent fifth gen formulas. You feel from a point of view of giving guidelines in a post RK patient. One, I think I would really love, though we've done RK and I agree, just two things I would like, which would be a imaging modality which would give the closest K, because you can look at it retrospectively. The second was which formula would be a preferred formula based on retrospective analysis. Have you actually done that? I'm sure you have enough numbers.
Again, the results vary a lot depending on, as you said, the incisions also. Like, for example, this is a much cleaner case cornea-wise, not keratometry-wise, but cornea-wise. So, in fact, I expected a little better outcome in terms of emetropia in this case. It's in cases where you have, 16 or 32 incisions where hardly anything is visible inside. In those cases, like for example, in this case, most of the machines and the readings, they were similar to each other. if I, so, they were ranging from 29 to 30, 30.5, which I would say is similar. It's not as if they were jumping around 3, 4 diopters. So keratometry wise, I was okay with it. It is the formulas which gave us a whole spread from almost 23 to 28.5. Now, and we had a lot of discussions as an academic exercise in the unit about this patient. And I think the ASCRS website itself uses multiple formulas. I was not aware of this actually. I sort of went into a little more depth in this for this particular case, and they happen to be using multiple formulas themselves. And I think that is why they are suggesting in the middle value. But I think this average approach is not effective because you probably tend to average out the mistakes as well, or group the mistakes. So I think it's better to stay on the extremes, as Dr. Anaga also said. Next time around, whatever is giving the maximum, I think.
I usually use
and
maximum and transient hyperopia is known, na? So maybe within 3 to 4 weeks that
yes, so on day one on day one he was plus 3.5. On this was last Thursday, and after 7 days post-op, he's plus 2.5. So I think little bit and probably some effect of the suture as well. I don't know how that will play out. So I'll remove the suture at 6 weeks.
Dr.
I think,
Saeed,
Anaga, just few points. RK is a real challenge for all of us. But if you look into this case, what Tushar nicely highlighted, had an 8 incision. And I could appreciate the optic zone was also quite good. Normally, in initial phase, we used to keep a very small optic zone. If you have a smaller optic zone, you have a much more fluctuation in the keratometry in these cases. So despite only 8 incision and optic zone, which was bigger than 4.5 millimeter, patient had already had a hyperopic shift. You can say his pre-op refraction was plus 2.5 and plus 1 cylinder. The hyperopic shift means the corneal profile has changed. The best would have been, anatomically, cornea looks quite okay, but we should have done the, corneal profiling by doing abrometry. All these patients should be done. We should have given us the, HOA, given us the idea of what type of spherical aberration this patient has. And accordingly, the type of IOL should be chosen. Because not every patient will have the, that positive spherical aberration, which can be counteracted by the negative spherical lenses. These patients do have a very high spherical aberration on a positive side. And most often, to be very, safer way, better is to put a non-aberrated IOLs. Maybe a plain monofocal lens would do very well in these cases, rather than going for these advanced monofocal lenses where the optics are already aberrated, which may compound onto the aberration which has this cornea would have had as such. That is one way to look into a choice of IOL and the type of cornea we're dealing with. And the second discussion which we are talking about is the IOL power. If I look into my own experiences, I used to love Haig's formula for RK patients, and it gives a very nice calculation for these patients also. Apart from that, we can look into Melanie's and Sama's formula. These are two very important formulas for, which are then a ACRS website. So out of these three, you can always go for a highest power, which Tushar nicely highlighted. On that also, normally I go at least 1 diopter myopia for these patient overcorrection. And you might land up with a, slight emmetropia or minus side. But never know, these patients behave so unpredictably in the post-op period as such. But I would consider, people listening to us, profile your cornea, look for whatever aberration this cornea has, then choose a IOL accordingly. And as we discussed in the previous case, you have to have a thorough investigation these patients also, posterior segment, other things. And as Tushar nicely highlighted, the suture might induce some sort of change in the corneal profile. Once you remove the suture, the plus cylinder might go off, and that also will decrease the effective, spherical equivalent also. A patient might do well.
Higgy's L, sir, in this actually gave even less. 24.5. So that's why that's one other reason why 26.5 felt like a sort of a reasonable choice, because Hagee's Hell has been quite effective in our hands.
That decision was
L
quite
is
good.
only for LASIK, no?
I'm sorry,
No, no.
Hagee's formula. Yeah,
Hagee's L for a
yeah,
LASIK.
yeah. No, I said, sorry, Hagee's the Hagee's formula itself gave 24.5.
Did you do
Yeah,
the
in this
PK,
case.
PK in this? Would
Yes,
PK help
yes. So
in
EK,
these patients?
for lack of time, I didn't keep that slide. So all the different zones were measured. And again, they again all ranged from hardly any difference of 0.25 or 0.3 was there as you increase the range. Probably, as sir said, that the central zone itself was pretty normal,
Yeah.
unlike the patient. So I think that's the reason for that.
Just one last question before we move on, Dr. Sai sir. If the patient has had an astigmatism, would you go in for a toric? Which patients would you avoid toric in post-RK? Or would you do a toric for all patients?
I don't think I would have gone for a toric in this sort of patient. Just one thing I wanted to comment was the intraoperative challenges in these sort of situations. Now, this was a clean 8 incision RK, which probably did not cause any problem. But I've had at least 3-4 experiences in 16 incision RKs where the incisions start opening up during the surgery. So you have to suture the incision and then go ahead with the phacoemulsification. And like Namrata madam rightly said, it's always better to go a bit scleral in these sort of situations. And recently I had a very interesting experience. It's not directly pertaining to this particular case, where a patient who had a 16 RK came with a blunt trauma with a total hyphema. And while the hyphema wouldn't just go away, almost reaching to the level of corneal blood staining, we decided to evacuate. And the 3 or 4 incisions opened up during evacuation. And we had a real tough time suturing all those incisions and then removing the blood clot. And when we went inside, there was a subluxated lens as well. So it was a really complicated situation. So I think intra-op, we have to be very, very careful. And once you put the sutures and all to secure your open wounds, then your astigmatism starts going haywire. I mean, I think you can't really predict any of these formulas or any of the predictions of IOL power.
But in a relatively clean case like this with only 8 cuts, and if the astigmatism in the central 3 millimeters is regular, then toric
Probably
IOL
yes, probably yes.
can go ahead,
Yeah,
right?
yeah.
Now, if you look into the aberration profile, if you have eye trace, it gives you whatever cornea you're dealing with. If your cornea doesn't have HOA, which is higher, and it's a stable keratometry, you might go for a toric lens.
But at least quantitatively, we can,
Quantitatively, I am using toric lenses in RK patients, but when it's crossing more than 2.5 diopters.
Yeah, you can debulk quantitatively.
And secondly, in those patients where at least 2 different modalities are corroborating both on the quantity and the axis of astigmatism. That axis alignment is even more important than the amount of astigmatism. If the axis is in alignment with 2 or more modalities, then I'm quite confident of putting toric lenses in these patients.
Okay.
So thank you so much, and let's move on. Dr. Shreyas Ramamurthy, he would be speaking to us on cataract in compromised corneas. So we are having a really nice discussion, analyzing each kind of situation very well. Yes, Dr. Shreyas.
Thank you, madam, and thank you so much, and thank you the rest of ARC also for having me over in this webinar. Really been enjoying all the discussions so far, and look forward to this discussions on this talk as well. So I'll be quickly running through there's a wide of situations where cataract surgery in hazy and compromised corneas can be a challenge. And, some of the more important conditions is what I would go through in the subsequent slides. The first, perhaps very innocuous, but very commonly seen, is really dry eye related to variety of ocular surface issues. And here, more than treating the dry eye and the comfort of the patient, it's really the challenge in biometry which becomes a problem, because many of these patients have punctate erosions, even if you're doing biometry as the first test without instilling any dilating drops or anesthetic drops, even then you can have wide variations in biometry. This was the patient on a first instance who had a 3 diopter of astigmatism, but because he had a significant dry eye and a lot of PEs, he was put on a course of topical drops. And the next time when his cornea was a little better, along with some soft steroids and cyclosporin, you could see that the astigmatism completely disappeared. It's essentially a consistency in biometry, which is something we need to look for in these dry eye patients, where you could have gone horribly wrong if you had just gone ahead with a toric IOL as in the first case. What we really need to do is look out for these dry eye, which can be missed quite easily in these cataract patients. Use sufficient lubricants. A course of topical steroid really helps in bringing down the subclinical inflammation, and thereby the punctate erosions also reduces. Using punctal plugs. In the post-op period, again, using medications for a short period of time, which are friendly, which are preservative-free preservative-free friendly to the cornea. Maybe reducing your duration of NSAIDs would all be helpful in ensuring preserving the quality of vision of these patients. In more severe conditions like SJS, OCP, or even other secondary Sjogren syndromes, it's important that we also modulate the amount of immunosuppression that the patient has. Now, this is a patient with Steven-Johnson syndrome who had a keratinized lid margin, and the previous eye had already undergone a cataract surgery and had undergone a melt in the cornea, which was performed elsewhere. Patient came here, I had to do a tenon patch graft and save that eye. But for this eye, we went ahead, even though there was a significant cataract, went ahead with a mucous membrane graft. Once this stabilized the cornea, even though the fornices were not very well formed, so I had to put traction sutures in place and then go ahead with the cataract surgery. The message here is essentially stabilizing the cornea before we go ahead with any form of cataract surgery. Even however dense the cataract, it can be dealt with at a later stage. But if we fail to stabilize it adequately, saying that, okay, it's a mature cataract, and I go ahead with the cataract surgery directly, this can have disastrous results. Many of these corneas, you have to phaco through the visible area, avoiding the opacities, and the tensile strength of these corneas can be quite poor. So applying a suture is important. And essentially, we are aiming for the best possible outcome. With the mucous membrane grafts and the fornix reformations, which was done in the earlier procedures, we are now able to fit the patient with a scleral contact lens. And with the scleral contact lens, the patient had a visual acuity of 612. So even in these very severe advanced situations, we can give good outcomes. In trauma, which is again another setting where the cornea can be significantly compromised, timing of the surgery is important. So again, even though this was an intumescent cataract, we waited till the sutures were removed, and you have to watch out for some fibrotic membranes and synechiae which might be present. While AC, in these cases, even sometimes the PC can also be breached. So doing safe phaco techniques, no hydrodelineation was done. We're just teasing the cataract out. It's generally a soft cataract that you encounter in these situations. Fortunately, in this case, the PC was not breached, but keeping a 3-piece IOL standby and putting it on the sulcus support would be useful in these situations. Moving on to a variety of keratoplasty situations. This was already discussed in keratoconic eyes, where you when to use toric and not to use a toric IOL. Now, this was a patient where I had done a DALG for an advanced keratoconus, and the patient developed a steroid-induced cataract. So before the onset of cataract, the patient had a good best spectacle corrected visual acuity, although had a fairly high level of astigmatism. So these are actually good patients when they have good spectacle corrected visual acuity to begin with and have repeatable keratometry on different devices. I went ahead with a customized toric lens, which was correcting almost 7.5 diopters of astigmatism in this particular situation. And these patients tend to have a very good outcome. Mind you, again, we are not aiming at emetropia here. A small residual astigmatism is still expected, but this patient went on to have an unaided visual acuity of 6.9, and then with a 1 diopter cylinder improving to 6.6. Again, in different graft situation, you can have this is a failed graft with a significantly hazy cornea where you're doing a combined procedure. So here in these cases, essentially improving the visibility, by doing deturgescence of the cornea with glycerol, then using chandelier illumination to do a safe phacoemulsification. Essentially, doing a good in the bag phacoemulsification, or rather implanting the IOL in the bag, becomes important, because during your subsequent bubble maneuvers, during your DSEC and DMEC, you don't want the IOL dancing around. You don't want the bubble to go behind the IOL. So having a bag which is not compromised, having a IOL which is in the bag, makes the rest of the endothelial keratoplasty procedure very easy. And then, as you can see, the rest of the procedure becomes very straightforward. Because this was a large therapeutic graft, I've gone in with the incision in the graft itself. But generally, we would try to either do a scleral incision. This was a 12 millimeter graft. But otherwise, in most of the other situations, we would try to do a scleral incision and avoid going through the graft. In other situations, it's a clear graft. But just to highlight that there can be a variety of challenges in these situations. Where some of these pupils may not dilate very well. Using a subincisional hook, ensuring that the iris is kept well away. Peripheral hooks are very, very important. Just limbal incisions for these hooks, so that during the entire procedure, you want to, this was an optical penetrating keratoplasty. So protecting the endothelium is extremely important in these situations. So these hooks ensures that your phaco can be in the bag. For paucity of time, I'll just move forward a little bit. So in the bag, you can see here that my phaco probe is always central, never leaves the center. And using viscoadaptive devices, coating with viscoat repeatedly can be of extreme importance in these situations. Now, a couple of situations when not to do a graft. Now, this is a patient where you have an adherent glaucoma. It's obviously the visibility is poor, but the patient has lived with this adherent glaucoma for a great part of their life. And it's just the onset of cataract now that has caused problems. So essentially what we need to do is put your incision away from the area opposite to the area where the glaucoma is, tilt the globe in the opposite direction so that you have visibility through the superior part. So you can tease the cataract out, chop it into small, small pieces, bring it, keep dialing it so that you're doing phaco in the visible area. And then subsequently put in a monofocal IOL. While you may not achieve a perfect refractive outcome in these patients, but these patients are extremely happy because they go on to get back the vision that they originally had before the onset of cataract, and that is satisfying. Another very important situation, this is an acquired opacity, but knowing when not to do a combined procedure. Now, this was a significant opacity and a dense brown cataract. A PK triple procedure would have been very tempting. But when I saw the other eye, the patient had a densely vascularized failed graft. And looking deeper, although this patient had a bacterial infection, this was actually a very neurotrophic cornea and had an epithelial breakdown, and then subsequently had developed a secondary infection. And he presented to us with a secondary infection. So looking at corneal sensations, blink rate, are all very small, subtle things which need to be looked at before you decide the choice of procedure. Although the cataract surgery itself can be challenging, and if you don't want to do a phacoemulsification, you do well even to do an SICS or an ECC in these situations. But phaco is possible, tilting the globe away in the direction where you have visibility, in the area where you have good visibility, and doing your chop maneuvers properly. One important thing is, if you're doing a phaco, ensure that you have completed all your chops and the chop is penetrated right up to the posterior crack. Because the last thing that you want in these compromised visibility situations is to have a zonular dialysis. So in case your chop is not complete and you try to start removing the cataract or start emulsifying, then the entire situation can go haywire. So you can see I'm doing multiple repeatable sub-chops, ensuring that I have really small pieces, and then only then do I proceed with the emulsification procedure. And then the entire procedure, it goes away quite uneventfully. And really the patient, although had only a 636 vision, for this one-eyed patient, this was a good outcome. And this is really what, it will be a stable outcome for a long duration of time, rather than a PK triple, which might have given a good vision, but for a relatively shorter period of time. This is a last situation which I'm showing. Again, this was a therapeutic keratoplasty. And because of the inflammation, the cataract progressed quite rapidly. but the patient also had a significant IOP because there was an intermittent cataract, there was peripheral anterior synechiae. So rather than doing a combined procedure, I thought I'll just do cataract first. Obviously, getting a perfect rhexis may not be easy in some of these cases as the capsule is already a little fibrotic and compromised. But the cataract is usually soft. And again, teasing the cataract, just coating with adequate viscoadaptive devices. And then in the post-op period, once the cataract surgery was completed, once the IOP came under control, the cornea actually cleared up. Although it was edematous before the cataract surgery, it cleared up. And only recently, after almost a duration of 5 years, did I have to do an endothelial keratoplasty for this patient. And the original therapeutic cornea lasted for a duration of almost 5 years. So in summary, it's important to know when to do a combined procedure, timing of the surgery, and when not to do, more importantly, when not to do a combined procedure. And I think that's really the message that I wanted to convey during this talk. Thank you so much for the opportunity, madam. Thank you.
Great talk, Dr. Shreyas, as always. Dr. Praveen sir, a question. In one of the videos, he mentioned that no synucleolysis to be done when there is an adherent leucoma. So suppose the adherent leucoma is almost near the center and it is hindering the phaco in the inferior part. So instead of doing a suboptimal kind of procedure because of poor visibility, if you use a very thin micro scissors from the side port or even from the main incision and just snip off the attachment, so you're not going to pull at it. So otherwise the endothelium and this thing can get affected, or they can actually cause a DMD. But if you just snip it off and then the iris comes down, it eases the process of phacoemulsification. So what is the opinion, Dr. Praveen sir? Dr. Titial?
I
Yes,
think,
Dr. Titial, sir.
Dekho, if you have the central adrenal leukoma, it's not going to benefit the patient at all. In that situation, I would rather do a keratoplasty and clear the central visual axis, then proceed. But yes, if it is little eccentric and there are addition there, either you use the iris hooks to retract the pupil from that area, which will expose some area for doing phaco. If it's a small stand, I might cut it. If it's a large adherence, then I'll not touch it because that's going to create a severe inflammation in those patients. So now, rather than doing that, I'll just hook the iris pupillary margin and try to retract, and that will give enough area for completing your phaco. That will be a more simplified way.
So I think sir said if it's an acquired lesion which has a central opacity with an adherent glaucoma, then a PK triple would definitely be the choice of procedure. Only in these congenital adherent glaucomas, like in this particular case, we would not avoid. And sometimes snipping off, while can be there, can result in a very large pupil. And these patients have generally a small pupil to begin with, and generally end up having a lot of photophobia and glare. So better, I would rather prefer not to handle the iris to the extent possible in these cases.
Okay. Dr. Haldipurkar,
Just
sir?
Just a point. I realize that a lot of these congenital cases, Shreyas, have eccentric fixation as well.
Yeah,
So
absolutely.
they are not actually seeing. So trying to fiddle around too much, sometimes the visual outcomes tend to be because they're already seeing paramacular. So trying to create vision for them sometimes is challenging. We've done exactly like that. In fact, in a Peters anomaly bilateral with a hard cataract, just did only the cataract part and left it. And those patients from a 1/60 BL are very happy seeing 636, 660. I think for mobility and follow-up, that's actually a very, very good idea.
Dr. Haldipurkar, sir, welcome.
Thank you. No, I kind of agree with Anand that yes, because their expectation is very low and surprisingly they do extremely well. Now, in such situations, what really matters is how are you going to operate these cases? Because with poor visibility, I think two things every surgeon, every young surgeon who wants to take up these cases has to remember. One, you have to stain the capsule. Number two, you have to use oblique light, because oblique light makes a difference between day and night, you see, because it's amazingly improves. When you have such light, such opacity, your coaxial light scatters and your visibility goes down. So I very often, or practically always, I put the coaxial light off and take just a simple oblique light, just that your assistant has to be good enough to hold it in the right angle so that you can complete your rexes, your nucleus management, everything with much better visibility than when you have a coaxial light. Otherwise,
How about the chandelier's illumination, sir?
well, see, chandelier will give you much better, but that will require you to make pass plan and put it in. So every cataract surgeon will not do it unless you are trained for posterior. But for a routine regular cataract surgeon, just holding it from the side also gives you enough of visibility, I think, and that is easily doable. Although chandelier is definitely much better.
And one last question, sir. In the case where he showed PK done and the iris hooks were being used, already in a PK case, you're using hooks. There are 4 more incisions. So how about using the B-octa in such cases?
Well, AC, it all depends on the amount of AC depth. In such a case, if he, like the case looked like a fully mature cataract, I'm sure the AC was also a little shallower. In such cases, well, I mean, if you're using dispersive viscoelastic, kind of decompressing the the intumescent lens and then put B-octa to go about, it's definitely
There's a
better.
very thin profile, sir, and even with iris hooks, actually you are reducing the chamber in the periphery because you are actually bringing it up. So that was one thought. Iris hooks definitely.
No. See, I have stopped using iris hooks. In all my cases, if I need a pupil to be expanded, I would definitely go in for a ring. And now with this octa, which has a very thin profile and it opens up the pupil very nicely, I think I fully agree with you. And in fact, I've seen one of the cases that you showed in one of the one of the groups. It was very nicely done. Congratulations! It's a beautiful ring, you see.
It's my go-to this thing now.
I know.
Our threshold has now reduced, for using because it really gives you very good visibility.
Yeah.
Right. So thank you so much, Dr. Shreyas, and this presentation. So we now move on to the next session. Dr. Tusha, are you here?
I'm here, ma'am.
Yes. Please share your presentation.
So,
So our next session regarding OOPS surgical disasters and comebacks. So we have Dr. Tusha Omprakash, who would be speaking to us on a challenging cataract situation. Yes, Dr.
yes,
Tusha.
ma'am. Thank you so much for Anaga ma'am for giving me this opportunity. So, is my screen visible?
Yes, we can see your screen.
Okay, just 1 second. So I'll be talking on.
There are times when capsular ruptures, resulting in events like nucleus drop, require us to abandon phaco for manual surgery. Let's integrate our ideas into a manual for performing safe phacoemulsification without unexpected consequences. Let's understand the dynamics associated with anterior vitreous face rupture. High fluidics and bottle height may cause spontaneous vitreous rupture. Unstable chamber conditions and increased turbulence with direct capsular trauma often result in anterior vitreous face rupture. A capsular tear risks rapid extension, anterior vitreous face rupture, vitreous prolapse, and nucleus drop. Miscalibrated incisions result in a major fluid efflux, destabilizing the chamber, causing ongoing iris trauma, meiosis, and hyaloid face rupture in the presence of capsular tears. Our goal is to conquer the fear of anterior vitreous face rupture and turn the once dreaded capsular tear into an ally. To achieve this, the prerequisites are meticulous preoperative planning with preoperative ASOCT is crucial in cases with pre-existing capsular tears. Matching incision calibration with instrument size is essential for excellent chamber stability with minimal leakage. Low IOP phacoemulsification with low fluidics works best with using active fluidics. Slow motion phacoemulsification, as described by Dr. Osher, maintaining equal or minimal pressure gradients between the anterior and posterior segments is also vital. In this case, there's a posterior capsular phaco punch. What next? Viscoelastic is injected at the area of the phacopunch for tamponading the vitreous. Parameters of 28 to 30 millimeter HGIOP and a low aspiration flow rate of 23 to 35 cc per minute are followed. The plan is to do slow motion phaco with low parameters. Nuclear hemispheres are slowly divided. Under no circumstances are nuclear pieces rotated. Nuclear hemispheres are taken out and emulsified slowly, keeping in mind the need to maintain chamber stability. The pressure difference between the anterior segment and the posterior segment makes the nuclear fragments float in the anterior segment without being pushed posteriorly. Low infusion of fluids causes negligible vitreous hydration, and the vitreous is not drawn to the tip. Careful repetitive OVD inflation, avoiding overinflation, stopped forward-back movement, and PCR extension. Dry aspiration of the cortex is done. You can see that the size of the PCR remains the same without disturbing the anterior hyaloid phase. A 3-piece IOL is injected. Triamcinolone acetate is used to ascertain the absence of vitreous. Preoperative OCT of this case shows pre-existing capsular defect following multiple anti-VEGF injections. Cataracts performs a 4.5 millimeter rhexis for optic capture and does femtodelineation, ensuring a 750 micron safety margin for the posterior capsule. Stable phaco settings based on 20 IOP are used. Calibrated incisions provide excellent chamber stability. The nuclear hemispheres are slowly divided. Rotation of the nucleus is avoided. There is low infusion causing minimal vitreous hydration. The irrigating port should not be directed towards the anterior vitreous phase. There is no undue deepening of the anterior chamber, no posterior bulging, and no extension of the posterior capsular defect. The thick epinuclear sheet, due to femtodelineation, provides a shield to the posterior capsule defect throughout the procedure. High sleeve retraction of the coaxial IA tip is performed to separate the level of irrigation and aspiration, simulating a bimanual IA. The epinuclear sheet is dislodged from all the ends and emulsified slowly. There is no peaking of the pupil. A 3-piece IOL is injected into the sulcus. Optic capture is performed. Triamcinolone is injected and shows the absence of vitreous.
Thank you so much, ma'am.
Very, very nice presentation, Dr. Tushar. You have shown both the cases where there is a pre-existing PCR in the second case because of intravitreal. I think nowadays with more and more intravitreal VEGFs being given, we have to face this situation, and in all these patients doing OCT before the surgery is very, very important. Dr. Haldipurkar sir, wanted your inputs on the first situation where there was a punch, right? So in this situation, suppose it was a much bigger PCR.
Yeah.
So what would you have done here? Fortunately, it was a very small circumscribed one, and you were able to, in fact, you still put in a 3-piece. One option was whether to put in a single piece also, because it was a very small peripheral PCR. Dr. Aldipurkar sir, your opinion.
Yeah. See, as long as it is a punch, your battle is not lost at all, because it's just that, see, there are two issues. When you have a clear-cut punch, whether the vitreous phase is going to be disturbed or no is one issue. And the second issue, which is more concerning to us, is how safely you're going to get your nucleus out. With a clear-cut punch there, doing nucleus management is not an issue. If you think that you don't want to disturb the posterior vitreous, so what we'll do is you'll use enough of dispersive viscoelastic. Now, these are some opportunities where you can do visco dissection. So where you have visco going behind and the nucleus getting separated from the posterior face. And then if you feel you want to further be safe, you can always get the nucleus out of the back and keep it, do a supracapsular phaco. But here his entire effort was to try and not to disturb the vitreous phase, and he's done it well. And to do that, obviously you have to play with your phaco dynamics, where it's a slow motion phaco, where you don't want too much of turbulence in the eye. So naturally you keep low, low IOP, low aspiration. I think Tusha, you've shown a good case. Both the cases, you showed a very controlled kind of phaco technique. Congratulations.
Thank you. Thank you, sir. Thank you.
Great. Dr. Gopal Raju, sir, are you there? Yes, sir. For all our younger generation and anterior segment surgeons, would you suggest them to learn, pars plana? And in these cases where there is a large PCR and there is vitreous prolapse, would pars plana vitrectomy be better in order to prevent, further traction on the vitreous? So please unmute yourself.
Yeah, I'll definitely suggest them to go beyond our boundaries of the limbus. So especially some situations where if you do an anterior vitrectomy through anterior approach, then that may cause in the extension of the PCR and then the more disturbance to the peripheral retina. So in such situations, we can put the IOL if there is only not much of a hard nucleus left behind. So cortex and then the vitreous can be easily removed through the pars plana route. So especially with the sutureless techniques, so we can easily learn the insertion of the irrigation and then the trocars. So where we can do a minimal manipulation vitrectomy and then the stability of the lens and the capsule can be maintained intact. Definitely, I would suggest them to
Thank you, sir.
learn.
Yeah, thank you so much.
Answering to your question, like you were
Yes.
saying that if the PCR is a bigger PCR, would I still go ahead with the phaco, and what will be the way to take out the nuclear piece? So basically, ma'am, as luckily in this, the hydrodissection was already done. So the capsular regions were already broken.
Mm.
So that's how it became easier for me in that case. But if the PCR is a bigger PCR, then you can also just take those nuclear pieces out and you can do an IOL scaffold also. So that's one more way to do it. But especially when you have a punch and when you're using low IOP phaco. So Dr. Mary Jose has showed that even when there is a vitreous anterior hyaloid phase disruption in one area where that punch is, the vitreous is still attached in all the other areas. So by using low IOP phaco, slow motion phaco, calibrated incisions, active fluidics, what my aim is not to disrupt the anterior hyaloid phase further and do the phacoemulsification in such a way that the punch does not extend, and at the same time with the use of active fluidics and slow motion phaco with the low IOP, I slowly take out all the nuclear pieces. So the thing is, like we have been regularly doing in all the pre-existing PCR cases, because as you rightly mentioned that due to anti-VEGFs and all that, we frequently encounter these cases, and regularly with this technique, we are able to complete phacoemulsification without any hassle.
Yeah, but in case of a suspected larger PCR, there should be no ego issue in extending the incision and getting the
That's a very
nuclear
good question.
pieces
So
out.
if there is an iatrogenic PCR, a larger
Okay.
PCR, which has led to the detachment of the anterior hyaloid phase, that time you are absolutely right. We can go ahead and do a SICS, or you can involve retina surgeons. But if there is a pre-existing PCR, especially in a case of PPC or other cases where the fibrosis is already there from a long time,
Comes in.
that time you can take that advantage of the hyaloid phase and use hyaloid phase to your advantage. So I take hyaloid phase as it's more like a friend to me while I'm doing phacoemulsification, and with the low IOP, active fluidics and everything, I'm able to manage these cases.
Thank you so much, Dr. Tusha. We'd like to now have Dr. Supriya Sriganesh for her talk on zonular dialysis and how she would be managing it. Over to you, Dr. Supriya.
Good evening, ma'am. I hope I'm audible.
Yes, yes.
Good evening, everyone. Thank you, ma'am, for giving me the opportunity to speak in this platform. It's been such a great learning, actually, listening to all the talks. And today you've given me the topic of zonular dehiscence. So I'm just going to show a few cases. Let's just begin. So the first case is one I did a couple of years ago, and I actually learned a lot from this case as to what is the sequence of doing the vitrectomy. I think that was the biggest takeaway from this case. As you can see, the incisions and the rhexis is uneventful, but note here that subincisionally there's a peaking of the iris after the rhexis, and I'm not really able to do my hydro. So I take the dialer and see this blob of vitreous coming out of the main incision. You can see the strand there, and that's gone in. And ideally, I would have loved to have done the vitrectomy at this point, but I chose to just put in viscoat at the incision and continue with my phaco. I have kept the probe a little away from the incision to make sure that the vitreous doesn't get further hydrated. And, that's one of the things that helped me complete this phaco uneventfully. I did keep my settings a little on the lower side with the foot pedal control. I was just around 350, 400 vacuum and lower flow rate, and completed this phaco uneventfully. And before removing the probe, it's very important to keep the antechamber stable. So I put in more viscoelastic before removing the phaco probe. So at this point, I chose to do a bimanual IA. I didn't see any. Of course, there's that blob of vitreous still subincisionally, which is there, which is what made the irrigation aspiration a little difficult at this point. You can see that there is vitreous. So again, stabilizing the chamber with the visco and coming out. So here, basically, it's important to just identify exactly where the vitreous strand is. This is a sweep technique, which I'm using just with a dialer. You just sweep over the iris and you can see that one strand of vitreous, which I'm just using a cutter to go in and just cut that strand of vitreous, after which, the iris just becomes regularized. So I don't go in with the bimanual IA again because I don't want to disturb anything. I just use a cannula to dry aspirate the rest of the cortex. So that's fairly easy compared to the previous attempt of bimanual IA. So at this point, things look fairly okay. So this is when I'm putting in the CTR. So the timing of placing the CTR is really important. Here, in this case, I didn't see any gross irregularity in the capsule margin. So the most convenient time to place it is after removing the cortical matter. But after placing the CTR, I do still have this issue. Our friend, the vitreous strand, is back. It's not been removed properly. So what I do is I switch to a coaxial IA and just hold the strand with the vitrector before putting in the infusion. And this time I make sure I do a thorough vitrectomy. So I go in that area and completely remove all the vitreous there. The CTR is in place, so it's slightly more difficult to do the vitrectomy. However, patience is key in this situation where you're just trying to go slow and do a thorough job of the vitrectomy. There's also a chance of vitreous hydration, so it's important to just keep the irrigation just above the iris. Here again, I sweep and make sure there's no vitreous. So I choose to put in a 3-piece lens because it'll be stable. I choose to put it in the bag with the haptic of the 3-piece lens in that area subincisionally. So just dial the lens into the bag, fairly straightforward. And at this point, the pupil is regular. It has become a little smaller. I choose to use pilocarpine to constrict the pupil. Now, this is really important when you have any doubt about vitreous, because you can see here, as I'm injecting pilocarp and the pupils becoming smaller, you can see the peaking of the pupil. So the iris strand, the strand of vitreous is there that needs to be removed thoroughly. And sometimes these can be quite stubborn. These just single kind of strands of vitreous can be quite stubborn. So a microforceps can also be used to just cut that strand. I'm able to hold that strand of vitreous very easily with my dialer, if you can see that strand. So I'm just making sure to cut the strand of vitreous with the micro scissors, and it easily gets released. However, this strand of vitreous is still in the antechamber. So just to make sure, I use triamcinolone, and this has gotten retracted behind the iris. As you can see, nothing gets stained. So the IOL is stable and the case was uneventful. But I think a very important takeaway from this case is if you see vitreous in the antechamber, do the vitrectomy early on so that you have a much easier case. So the second case I'm showing is actually one of our fellows was doing a stop and chop for this case. Here you can see she's done quite a gross sort of lateral separation, and she's doing a stop and chop here. So she just goes in with the phaco, and again, this is where the ZD happens. So you can see it's a dense cataract. It's almost a grade 3 to 4 NS. And there's very gross manipulations happening here. And on the left-hand side, you can see that the nucleus is tilting a little bit. So this is when I took over and just checked, put visco and just checked. You can see that there's a strand of vitreous here. So there's been a ZD, probably a 2 to 3 clock hours ZD with a little bit of vitreous. So here, I'm wiser at this point. So I make sure to do the vitrectomy early on and remove all the vitreous. So here a thorough vitrectomy is done to make sure. And one of the clues that couple of clues that you can actually see is the shape of the iris, the pupil shape, and also the shape of the anterior capsule. Here, it's a tricky situation because the capsule was not stained and it's quite a dense nucleus. So I here choose to stabilize the bag because it's quite unstable. I'm not able to dial the nucleus. So I use a capsule hook. Now, some people use iris hooks in place of capsule hooks, but I don't suggest that because capsule hooks have a wider base and they can really hold the capsule. They're also angulated differently and they're much longer. So it goes all the way till the equator and really holds the bag very stably. So here you can see I'm able to easily rotate the nucleus after putting in the hook versus, previously that I wasn't able to move this. Now at this stage, I don't want to put in the phaco. I just want to try and put 2 dialers and divide the nucleus, make sure it's fully separated before I go in with my phaco. And again, here I'm trying to stay, this is one of the worst positions to have a ZD, because that's exactly the left upper corner is exactly from where you pick up your pieces during phaco. So it's a little difficult to avoid that area during phaco. Here, I'm just readjusting my capsule hook. You can see the patient's eye movements are quite gross because this case was under topical anesthesia. And so here again, I restabilize the capsule with the hook and just rotate the nucleus a little bit into place. It's important not to manipulate and do too much of a lateral separation. Again, here, I choose not to pick up the left upper corner piece. I choose to pick up the one on the right because that's the more stable area of the bag. And I'm just trying to avoid the left top corner. So I've fast forwarded the phaco, but I am bringing the pieces into the safe zone, not completely into the antechamber, but into the safe zone. And here again, going low and slow and doing a slow-mo phaco with low settings and always stabilizing the chamber before you come out. So half the nucleus is out. Now here I decide to bring the piece into the antechamber because I'm not very confident that the bag is stable. So the pupil size is coming down. I'm more confident in bringing it into the antechamber and completing the phaco, all while injecting visco multiple times during this process to protect the endothelium. And at this point, after the phaco is done, I'm now removing the capsule hook. I just want to assess the situation, how stable is the bag? Can I get away with a CTR? So removing it is just very easy. You just push it forward and then bring it back and rotate it out. Now, at this point, before the cortical removal, I'm choosing to put in the CTR because the bag on the left side is not very stable. Putting it in through the side port and using a two-hand technique here with two dialers. So one dialer goes in to stabilize the CTR. The other Sinski hook goes into the hole, and then you just retract it and make sure it goes into the bag. So this is two dialer technique. I switched to coaxial illumination because the red glow wasn't very good. Here, I just want to show the importance of this side-to-side movement while removing the cortex in the area of the ZD. This really loosens the cortex. You can even, with the hydro, hydrate the cortex a little bit to loosen it. And be very slow and very patient during this step because you can worsen the ZD and the whole bag can become unstable and it can tilt after putting the lens in. So that side-to-side movement, here, see, I'm hydrating the cortex so that it loosens up before I remove it with the IA. Some piece of cortex is left. It's important not to, really go after each and every strand of cortex. You can do it after placing the lens when everything is a little more stable. So here, since the bag is intact and everything looks good, I'm placing the regular monofocal lens that was planned for this eye and removing the last piece of cortex. Now, here you can see that the pupil has come down quite a bit. And on the left side, again, there's a little bit of peaking of the pupil. So here, again, it's important to do a good vitrectomy. See, I just do the sweep technique again, and I can easily find exactly where the vitreous strand is, and it comes out of the side port. You can see that it was coming out of the side port. It goes back into the antechamber. And I do that last bit of vitrectomy to remove the vitreous strand. Now, in these cases, it's really important to use pilocarpine, constrict the pupil, and see if there's any kind of peaking. And not only pilocarpine, the way to inject pilocarpine also from periphery to center, just so that, again, you can sweep any vitreous that is there. And also make sure you inject the pilocarpine on top of the iris so it has maximum effect. So you can see the pupil is now nicely constricted, and I'm using triamcinolone in the antechamber. And when I'm trying to wash it out, you can see there's a strand. So this is the importance of actually using triamcinolone, and you can just remove that strand. So there's no vitreous in the antechamber. So everything looks good and stable, and I've made sure that there's no vitreous and the lens is stable in the bag. Just hydrating and closing the case. Ma'am, is there time for, I had kept one more last case.
Yeah, we are really a little short.
Running late, so I'll just skip that.
Yes. Thank you. It was a very nice presentation. Dr. Aldipurkar, sir. Yes, actually, just a few points. In the first case where you were showing, can you please unshare? Yeah. You showed the iris sweep technique to where the pupil was peaking a bit. You can unshare the screen. So would using tricot at that point of time itself help so that you can go exactly at that point and do a vitrectomy and remove that strand? Because even when you do a sweep, you are not exactly sure where we are cutting and there could be still some residual vitreous. That is number one. Second case, when you thought that, when you removed the capsular hook and you put in the CTR, the pupil had really come down. So when there's already reduced visibility, you can't see the anterior capsular rim. Putting in a CTR blindly could be a little difficult. Did you try using phenocane and try and dilate it and at least then put in a CTR?
Yes, ma'am. I did use
It would also
adrenaline and
work.
try to dilate it. Even with visco, I did visco dilate it. But also another thing that I did, which probably got edited out of the video, was just retracting the iris and seeing the edge of the anterior capsule so that you know where you're going. I think, and also angulating the CTR so that it's slightly tilted downwards and you know you're going into the bag. That is another probably a point that can be kept in mind.
So in a small pupil putting in a CTR, sir, any tips in such a situation?
Well, let's go from the first case. in the first case, Supriya, anyway, both the cases are very well managed. Compliments to you.
Thank
But
you,
what I wanted to share was, like in the first case, the moment you started, you saw the peaking of the pupil and the vitreous coming. That means now these are the cases where detailed pre-op examination of the slit lamp can give you some clue with regards to either phacodonesis or irregular iris, or when you dilate fully, you might see some gap between the iris and the lens. So I think that's very important. And second thing, like how Anaga said, it's always better to use diluted triamcinolone because it can identify your vitreous strands so much better. You did that, sweeping and then cutting it with cutter. You can do that much better when when you can see your vitreous strands more clearly. That was it. And in the second case, like again, Anaga pointed out, when the hook was in place, when the capsular hook was in place, you had enough opportunity to remove most of the cortex from the other areas. Instead, what you did, you took out your capsular hook and then you tried to put endocapsular ring. And the thing is, even if you want to put endocapsular ring, if you have hooks in place, you can do it as a better job. But cortical removal with endocapsular ring in place is always a little more difficult.
Difficult, yes.
So at least in the rest of the area, you could have easily removed the cortex before the endocapsular ring went in.
Definitely, sir. Yeah, I agree.
It was a difficult case and the pupil was coming down. And with the ring in place, you did your cortical aspiration pretty well. Everything else I'm okay with. But even in the second case, I kept feeling that you're a little stingy with your triamcinolone.
Yes.
Why do you use it
I
only
could have
at the end?
put in
You can put it
triamcinolone a
in
lot
the
earlier. Yes, ma'am, I agree. So what's happened in a few earlier cases that it goes posteriorly and that makes the visibility a little difficult. So I definitely am a little stingy with it, but I think I for sure could have injected it much earlier. The strands would have been much better visualized with the staining.
Very well managed. Thank you. Thank you so much.
Congratulations.
Thank you. Thank you so much, sir. Thank you, ma'am.
We'll move on to Dr. Anand Parthasarathi. He would be also presenting a challenging case. Yes. Can please.
I kept the just to one case in view of time. So, all right. Yeah, my slides are visible.
Yes, yes. Yes, you can go ahead.
1 second. So, just to give a brief history of this case, this is a therapeutic keratoplasty done about 2 months before this patient presented. Fungal keratitis, responded well to early, came with a perforation, so responded well. We did a standard 8 mm graft, covered and had good recovery. We did use an optical PK tissue because I prefer to give the graft a chance. Post-op, the graft responded well to the antifungal and the steroid treatment after 2 weeks. But the patient presented 2 months later with a mature cataract. And you can make out that the iris is actually plastered. I thought this should be actually quite easy. So I said, we will plan for a toric IOL, which we discussed, based on the keratoplasty. And also that I felt this should be actually straightforward. But as I started the procedure itself, we did stain. We are using a fair amount of viscose. I marked it at 150 degrees, as we normally do for our cases. So everything looks to be going well. What is important is probably I didn't realize is that the capsule is actually very stiff. So this is something I do in slightly hypermature cataracts, is to just puncture a round rexus with the phaco probe. The Mohan Rajan calls it puncturexis. But the challenge was basically to extend this in a round manner, which is actually easier. I did get an opening because it's a soft cataract. I decided that I will actually just go in and do an phaco aspirate an IA because it's a very, very soft cataract. But you can make out a whole membrane on the anterior capsule. There's a lot of pigmentation. So in these cases, it is extremely challenging to actually get a proper rhexis. The cortex is actually very soft, but you can make out it's a very, very irregular cut of the capsule. So in these cases, it's maybe a good idea to actually do the excision maybe with a vitrector or a proper scissors. I did enlarge the whole rhexis to at least about 4.5 millimeters. Remember, I am using a customized toric lens. Now, the challenge is there are multiple areas of thick capsules. You can't actually get a complete cut around. I've got only a 4 millimeter rhexis, and I realized that this shot probably should be enough at least to put the plate haptic lens. So I just remark. I'm of course using a fair amount of viscoat. Being a corneal surgeon, for me, the endothelium is probably the most important part of the cornea because post-op, it will tell you whether it's responding well. So I just remark it. The incision is just about scleral to limbal. I insert the bag at the lens directly inside the bag. And this is important because if you don't do that through a 4 millimeter rhexis, is extremely challenging. So I decide that I need to implant the lens directly into the bag. Now you can see half of it is in the bag, half of it is lying outside the antechamber. And this manipulation has to be done very gently. You can make out a lot of anterior capsular tags. And this is something I didn't anticipate that it could be so challenging. There are some pieces of loose cortex lying around, but I actually was able to put it as per the mark. You can make out the irregular margin of the rhexis, but it's actually well aligned. I go back in, I remove all the loose cortex, and I'll probably have to be happy with this kind of a rhexis because this is probably the best I can get in this patient. I do suture the lens, do suture the wound just to make sure that there is no leak post-op. The graft remains clear now about 6 years post. The IOL is in place and patient actually did well. It's about 612 uncorrect. That's my case. Thank you.
Very nice, very nice. Even I've had a case post PK where we have done smart toric, Ultima smart toric. Can you stop sharing, please? Yeah. So these cases really do well. One tip in these smart toric lenses is you should never put them upside down, you know. If they are put upside down, then they can actually cause residual astigmatism and unexpected post-operative astigmatism. So you need to be very careful to put them in the right plane.
This was a customer from Zeiss, where it's actually the toricity is in the back part. So you have to be careful about the orientation.
And they are a little thick. These lenses are a little thick. So actually, as they are unfolding, if you can just tap in the lens inside, that is the best. If you wait for it to completely unfold and half of it on the main incision side is outside, then you need to literally fold it and then put it into the capsular bag. And that can cause a anterior capsular tear sometimes. So these are really challenging cases. We now move on to our last case. Dr. Srini, are you here?
Yeah, I'm here.
Yes, yes. Can you please share your screen? So he would be showing a challenging case too on a rock hard eye. So please share your screen. Yes.
Yeah, you can see, right?
Yes, yes, we can see.
Yeah. So this is, I'm scared to present this in front of my teacher, TPI sir and Suha sir. So but I had to face it a few times and I thought I'll share my experience on it. So this was one case in which everything, a clean takeover, everything was fine. But towards the end of, when I was doing the aspiration and just talking about it, just iris started coming out. There was no issues till then. Absolutely nothing. Preoperative, intraoperative, nothing. The iris started coming out. I could represent.
Srini, your audio is not very clear.
Yeah, there is some issue with my internet connectivity. Can you hear me?
Yeah, we can hear, but
So
please
I'll,
go ahead. Hmm.
okay. So this is so I had similar cases before, and so what 2-3 cases before, and in those cases what I did was I postponed the cases, took up the cases after 2 weeks, and I put the IOL. So what got an indirect chromoscopy done, it is not supracorneal hemorrhage. Okay, so this is not supracorneal hemorrhage. This is the fluid getting misdirected into the Burgess space through the zonular, and once the fluid goes there, the fluid pushes the posterior capsule forward. It shallows the anterior chamber. It goes on from there. So it causes an increase in intraocular pressure. Eyeball becomes hard. So here in this case, the IOL was open. Actually, everything was going on well. So I had to decide what to do in this case. So, so there have been quite a few. So this is another case. Here, the same thing was there, and so what I did was I didn't postpone the case. I didn't do anything. I just took the patient to the preparation room, gave IV mannitol, and took the patient after about 1 hour. So by that time, I had softened. I could found the anterior chamber. Iris was not coming out, and I could implant the intraocular lens into the bag. Though it is not that way easy. It's a technique. Once it's a stiff lens, so with that, kind of a 10 cc, putting the IOL is a bit risky, but I could manage to put the IOL in the bag. So here, in this case, what was done was the stopped it where the problem happened, took the patient out, mannitol was given, which brought down the IOP, dehydrated the vitreous, and got the CCC. Here, though I'm able to put the intraocular lens, it is not that comfortable. So I didn't have to leave the patient FAT and take the patient for secondary IOL implantation later. So this is something. So this is what happens, especially in those eyes short axial length and all. It's always an uneven full phacoemulsification. And towards the end of phacoemulsification or IA stage, all these things happen. It is basically the fluid getting misdirected. So this is one study. So I show you a lot of studies on this. In this study by Oliver et al., and they showed that in these cases, pars plana aspiration of the fluid. Mind you, it's not the vitreous that they're aspirating. So it's just we are all tried aspirating vitreous and endophthalmitis cases 26. It doesn't come up. It is the fluid that is there in the Burgess space that comes out to 2016, but 2018, it's smaller gauge needle is fine. The risk here is not the vitreous fraction, but you damaging the posterior capsule. Here, this is the first case. The fluid was aspirated, everything was fine there. The eye became soft, the anterior chamber became deep. Absolutely, very comfortably, the IOL could be placed in the back. So the case in which the mannitol was given, you could see the struggle that I had to put the IOL in the bag there. So you can see, I can go even under the IOL to aspirate. So this is acute intraoperative rock hard eye syndrome, many names, acute fluid misdirection syndrome. So as I said, a lot of studies driven from 1994, 2009. All these studies have actually recommended pars plana decompression. Only one said use a small gauge vitrectomy to actually cut the vitreous. So this is another case in which I had. Why so I've had probably about nearly about 10 cases in my last 25,000 cases. That's quite a significant number. I definitely agree that it's a significant number. One issue, Kusha, and everyone talks about low IOP. So I go for a sort of high IOP in my signature pro. My body height is 106. Probably that is the reason. So I keep all the settings extremely high. Probably. So this could be one lesson that it shows that it is better not to have a very high body height and go for it's basically a fluid going through it. These are the risk factors on an axial length, pseudoexfoliation, laser API, shortectomy. All these are risk factors, and the highest risk factor is if the patient had it in the other eye, then you have to be careful. See, in the beginning, you do all these things. I did all these things, elevating the speculum, lowering the body height, all these things were done. Despite that, the IOP didn't come down, and I had to somehow become a. And before you go for this, I'm not telling that this is. If you ask me what is the ideal method to do it, just postpone it, take it after a week or so, then everything will be fine. And if you are going in with the needle, surely you should rule out supracorneal hemorrhage. And I've done it in all the cases.
Srini, can you please summarize? Yeah.
Yes, that's it. That's it.
Okay. Thank you. Thank you so much. I would like Dr. Aldipurkar sir, Dr. Sai Kumar sir, Dr. Gopal Raju sir. Can you please switch on your videos? Yes. Yeah, this was one way of doing it. If we put in a trocar and then do just a passive vitreous decompression, will it be safer? Because going in with a needle very close to the posterior lens capsule, there is a very high chance of creating a iatrogenic PC touch. Any opinions on that?
Keep the needle there. If trocar would be much safer, I agree. But we don't have to aspirate. There is fluid there. It'll come.
Sorry,
In fact, just putting in your MVR, going to the center and just coming out itself, a small egress of the fluid.
Just a passive.
Yeah. And just with the MVR itself, if you can just open the edges of your sclerotomy, that itself should be more than enough to give you enough space to go ahead with the rest of your phaco. But as Srini said, if you are very careful, you can see the needle very clearly through the capsule. You can just go under without causing much of problem. And as he pointed out, not too much of vitreous is coming out when you do that. It's just that fluid which has got trapped under the capsule. So I don't usually aspirate. I just put in an MVR and release some fluid, which is more than enough for me to go ahead with the rest of the procedure.
Yes. Thank you, sir. Anybody's opinion, or we'll go on to the grand rounds, only 2 to 3 cases? I'll just start sharing. Can you see my screen?
Yeah.
Yeah. I'd request all the expert panels to switch their videos on, please. So we already saw a post-RK case. Now this is a very interesting case. This was a patient, one-eyed patient. Right eye RK has been done in 89 and LASIK also has been done a few years later. And now the patient last 3 years is coming with diminished vision. So you can see those RK cuts here and you can see these deposits, metallic deposits in the interface. So this is the patient and he is a one-eyed patient. Now you can see even the corneal OCT is showing those deposits in the interface. This is the topography of the patient, which is showing the central myopic ablation also and a higher order aberrations. Spherical aberration is very high. This is the pentacam holiday report, which is showing the very great keratometric variability. And this is the biometry of the patient. So in this biometry, this is the right eye of the patient. On this part of the screen, you can see this is the post-LASIK mode. And on the right, you can see the post-RK mode. Now in the post-RK mode, I have selected the same lens. This is, for example, the Technis lens. With the Barrett True-K, it's showing an IOL power of 21. Whereas with the Barrett True-K, with the post-LASIK, it is showing 23 and the Haigis-L is showing 27. So now my question is to all the panelists, what IOL power would you choose for this patient? Dr. Titial, sir?
As we discussed in a previous case, these cases are very, very difficult to actually get to a proper power. If you have access to some other modality, like, intraoperative, and those are actually, sometimes helpful, on the table to judge what would be the power which is coming through aura. And then you can judge, you can compare with Barrett True-K and Haggis and go for a slightly, higher power in that area also. But if you don't have access to aura, it depends how have been your experience with various formulas in these cases. And that thing which may be suitable here.
So this is
But
post-RK
going with
and
the
post-LASIK.
complication when RK also done, the LASIK also done, and the entire, topography changes and very high order aberration is also high. I might go with the, this particular case, Barrett True-K, because it's more of a LASIK case now. So maybe I'll go for, one diopter myopia on this and go for a Barrett True-K in this particular case.
So would you go for a intraoperative refraction, like do the cataract surgery and
Yeah,
also
that can also be done, yeah.
That is
so
also
that,
an option. Yes, yes, yes. So what we did in this case,
Just a query. I'm wondering whether there's a possibility for you to consider, especially in some patients like tough RKs where you're getting a lot of variability in the range of IOLs. This is about 2 diopters. But if you have 5 to 6 variations, I'm wondering, anybody thought about doing it in 2 stage where you only remove the cataract,
yes,
take it
that's what you
back?
can. Yes, yes. Same thing. We can do that also. But here in this case, what we did was this is on the left. So we put it on the ASARS online calculator. Post LASIK, max was showing 26, 25 and post RK was showing 21. So post RK and post LASIK, the difference was quite large. So we went on to the more myopic side and then we chose 25 as the final because it was showing post LASIK, it was showing 25. So I went on to that. And patient also wanted a femto. I would not go into these details. So important is to stain the capsule in these patients. And then the cataract surgery was as usual. Fortunately for me, the second day post-op patient was 6'9" and auto-ref was just minus 0.5, -1. So there are not so many cases in literature also which give us a proper guideline on post RK and post LASIK cases. So these are, and I didn't even have the other eye for comparison. So these are extremely difficult cases. Let's move on to the next case. If it's a silicon failed eye, Dr. Sai Kumar sir, are you there? So the same patient, now one of our optometrists did not actually put on the silicone oil mode. So on the left, you can see that it shows a 22.5 diopters. But yes, when we noticed it, silicone oil mode 25. So just for the benefit of the delegates, can you just explain? So in a case where the silicone oil filled eye, and if you are planning a silicone oil removal in the same sitting, then which IOL power would be chosen and how would you go about it?
If you're planning an oil removal also in the same sitting, then
Yes.
the obviously now the standard of care is an IOL master 700 with the silicon oil mode, so that you very clearly shown. Now regarding the IOL power, I would off late I'm going directly with the whatever power is given to me in the IOL master 700. I am not planning to make much of corrections on that because otherwise you might end up with a hyperopic refraction.
Right. So here it is showing in the silicone oil mode, it is showing 25. But this is with the silicone oil in place. When we are planning a silicone oil removal in this patient, would you go ahead with the 25 or with the 22.5?
No, it is
Okay,
clear
Tityal,
that,
sir.
if you look into the first biometry, the axial length is, 22 point something. And if you go optical biometry, it's 21.55. That's the accurate
Both are optical.
biometry.
Both are optical biometry only.
So silicon mode you have taken, no? That's an accurate biometry, and we should go for that only because we are going to take out the silicon towards the end of surgery. So it's like a standard, calculation.
Right. So this was one case. Now again in a very high myopia. Now this was a patient where on the left you can see this is the Barrett Universal 2 which is showing minus 0.5 and the SRKT here is showing minus 2. So in the extremely high myopia cases when there is a difference in the IOL power by two different IOL formulae, then how would you proceed? Dr. Aldipurkar, sir?
Well, when it is minus 0 and minus 2, I normally prefer to go for a higher one. That means in this case, I would go for the one on the left side, that is minus half. Because at the end of the day, whether you put minus 2 or minus 1 or minus 3, the post-op refraction, there's not going to be much difference. And here, so when you are in doubt, I think I would go for something
Yeah,
which is
more myopic.
yeah. But then why it's what and now
This is
obviously
from the IOL formula.
okay. Parrot Universal. All right.
So this is the
But
last case. Yeah. Yes.
no, but we know that in a Barrett, it really does a good job when it comes to high myopes. Earlier, when Barrett wasn't there, we would use other ones. But here, since the Barrett has come, even for high myopes, it seems to be working good.
Good. Yes. So this is the last case. This is a patient right eye trifocal IOL done elsewhere. Patients come with 6/12 partial vision is dropped, and she's now on OCT. We found this epiretinal membrane with increased macular thickness, and she has a cataract in the left eye also. So when we are planning a cataract surgery in the left eye, now this right eye a trifocal has been put in. So what IOL would you put in the left eye? Dr. Titial, sir?
No, considering if other eye also had a epiretinal membrane.
No, other eye, left eye cataractus eye, its OCT is normal.
Okay, then
She's
I
a
think
62-year-old, not very old.
this case as such going to be difficult. The existing pseudophakic eye, and I might go for a simple monofocal lens in other eye to give him a very nice enhanced vision, clarity and contrast. Because ultimately this particular eye may require a surgery in future, and the entire multifocality is not going to help this lady. So my decision would be if patient agrees to my concept, I might go for a monofocal lens for this patient.
Or an advanced monofocal add-off.
Not at
At
all.
least to give her in the other eye, but that eye OCT is right now normal.
You have one eye, you have a trifocal optics, another eye, modified monofocal optics. that's going to confuse the patient much greater, And any eye which has the problem, like with the trifocal, with the advanced monofocal, if you other eye sees better, that compensate the the fellow eye. I would rather give a better clear vision with a normal aspheric monofocal lens, and give him a better quality. What is the opinion of other people?
Agree fully, sir. Because even the EDOF lenses, although there are no rings in it, there is, I think, there is some loss of contrast.
Definitely.
Not to the level of a trifocal or a multifocal, but there's some loss of contrast. So a plain monofocal lens would be definitely my choice. And as sir said, this eye will probably require a vitrectomy with an ERM removal later on, and the eye with the normal retina will predominate.
Dr. Aldipurkar, sir, any difference of
No,
opinion?
I fully agree. I think at least one eye should get pristine, clear vision, which you are.
Not even advanced monofocal?
I have my reservations about EDOF. EDOF is good, but monofocal aspheric is.
Yes.
We want to play safe in this eye, but advanced monofocal also, there is no glare and halos. We are not playing with aberrations in that sense,
Okay, छोड़ दो. For Dr. Anaga, we'll put an advanced monofocal.
The patient is obviously, she has been with good vision, with good near vision in this eye, but only of late the vision has dropped. So that was the only question.
Now, that can happen in the left eye also.
Also, right. But as we now already we keep telling, in cases of advanced monofocals, even if there is a little ERM, fine ERM, they still do better, and that is why our indications have increased, right? That is what we propagate for those patients.
I at least I don't know about Jeevan or Sai, but for me, if it's not a pristine macula, I think even EDOF, I'm not very confident about. Because
Okay, no
That is
advanced
true.
monofocals, nothing. Just
I
plain.
highlighted this point, when Dr. Tushar put a, IHANS, lens, monofocal plus lens.
The
A
RK.
patient who already has an aberrated cornea. As far as I'm concerned, it's not acceptable for a quality of vision for a patient. Yes, if some patient might demand that, because nowadays to undo the mental thought of a patient is very difficult nowadays. They come with the idea of, I want only EDOF lens. Then it is a challenge. So sometimes it requires a multiple, counseling these people. Okay, you go and meet Anaga, you go and meet other people, then come back. Whether you have all the opinion, then satisfy this person.
They even come and tell us what brand we have to put.
Yes. And there are very few patients nowadays who come, doctor, whatever you feel better for me, please do it. Very few patients. Most patients say, I want this. And why you're saying no? Please explain me why no. And it is a long care time with these people. But as far as we are concerned, we should give them objective points. See, this is your cornea. I've done the aberrometry. This is the aberration. And this is the IOL. Maybe they'll understand. But otherwise, some people, especially post-refractive surgery patients, they're adamant. They said, I want a multifocal lens. I want to see better. Without they realizing they had an ERM in the back or a myopic, some sort of a CNBM there. They still want this thing, I think it is up to us to, how to we convince these people,
Thank you. Thank you so much, everyone. And I think it has been a great session today. I'd like to thank all the expert panelists, each one of you, for sparing your valuable time so late in the day and being with us throughout, and all the speakers who were fantastic in their presentations. We have had a great range of topics where we have had extensive discussions. Thank you so much, AIS ARC, our AIS president, and our chairman, Dr. Prashant, for always guiding us. Thank you, everyone.
And I did wonderfully well, to withstand the entire 2.5 hours of a discussion. Many people had switched off there, You did wonderful, and you moderated a session as you do routinely for all ARC meeting for last now 5.5 years.
Thank you so much, sir.
Let's hope you do a much better.
Thanks, Anaga.
Thank
Really
you.
wonderful.
Thank you so much.
Thank you so much. Thank you.
Good night to all
Thank
of
you,
you.
Mr. Sunil, for the support also. Thank you. Thank you so much, sir.
I think Prasad should be very thankful to you, bound